Okay, we are now recording. Welcome again to class. Hopefully you're getting into a good routine of how this works. So these presentations, we have Group 8 here, and they're going to be talking about Medicaid and Medicare, which of course is some big topics when we're dealing with healthcare and healthcare administration. For the sake of Samantha, who is here on vacation, all the way on the East Coast, it's late at night. We will dive right on into it and let them go ahead and take it over. I might even be a little nice, and we may even forego some question and answers at the end. We'll see how I feel. How's that sound?
It's good to me.
All right, go ahead.
Okay, well, I can introduce our topic.
Okay.
Yeah. Group 8, we covered Medicaid and Medicare, and this is Kimberly Harvey, Cheryl Fuller, and Samantha Frederick. Next slide. So we'll start off by talking about the history of Medicaid and Medicare. I just covered some general different timeline events. If I went into all the deep things that went into forming Medicare and Medicaid, we'd be here for a couple hours. But I'll go through the bullet points that I took notes on. So Medicare was created before Medicaid, and it started through the national health care coverage. It started to be discussed in 1912 by President Roosevelt. And then in 1945, President Truman proposed the idea to Congress. And then when President Kennedy was president, he pushed for this coverage of 65 and plus because he realized that 56% of those that were 65 or older had no coverage. But it wasn't until 1965 when President Lyndon B. Johnson finally signed legislation to put Medicare into action. And actually in the top right corner, you'll see a picture of this legislation being signed by President Lyndon B. Johnson. And then we go on to the history of Medicaid, and that started with the Social Security Amendments of 1965, created Medicaid by adding Title 19 to the Social Security Act. The Children's Health Insurance Program, otherwise known as CHIP, was created in 1997 to give health insurance and preventative care to nearly 11 million or 1 in 7 uninsured American children. And then in 2010, the Affordable Care Act brought the health insurance marketplace, a single place where consumers can apply for and enroll in private health insurance plans. So next slide.
Okay, so there's 4 different parts of Medicare. Part A, which is considered original Medicare, it provides benefits and coverage for inpatient hospital care, inpatient stays in most skilled nursing facilities, and hospice and home health services. Part B, which is also part of original Medicare, provides benefits and coverage for doctor and clinical lab services, outpatient and preventative care, screenings, surgical fees and supplies, and physical and occupational therapy. Part C, which is Medicare Advantage, it actually is just combining parts A and B into one plan. It can also be combined with Part D to create the Medicare Advantage prescription drug plan. And I'm going to skip down just since I already talked about it. Part D can be standalone or combined, and that's just prescription drug coverage. So generally, they're offered by HMOs, PPOs, private fee-for-service, and special needs plans. This is it not?
So next slide. Federal issues of Medicaid. CMS issues guidance by sending form letters to state Medicaid directors, letters to state health officials, informational bulletins, and frequently asked questions to communicate with states and other stakeholders regarding operational issues related to Medicaid. These are used to provide states with guidance and clarification on current information and statutory changes regarding Medicaid. They do not establish new policy. They are designed to highlight recently released guidance and regulations and to share operational and technical information. Next slide, please. So the state issues for Medicaid. Medicaid is unique in that it operates according to each state's statutes within broad federal guidelines. General rules that apply to all state Medicaid programs include beneficiaries are eligible for services at the time they are furnished. Services are provided by licensed, qualified Medicaid-approved providers. To the extent required by the state, services are medically necessary. To the extent required by the state, medical necessity and medical rationale are documented and justified in the medical record. Accurate, clear, and concise medical records are maintained and available for review and audit. Physician's orders or certifications are in the medical record. Next slide, please. All medical records entries are legible, signed, and dated. Medical records are never altered. Services are correctly coded. Only covered services are billed, and overpayments are returned within 60 days. So that covered for Medicaid. So next slide, please. So these are the federal issues for Medicare. Medicare faces a number of critical issues and challenges. Some of these include providing affordable quality care to an aging population while keeping the program financially secure for future generations. Changes to Medicare have been proposed to address financing challenges by restructuring Medicare benefits and cost sharing, further increasing Medicare premiums for beneficiaries with relatively high incomes, or raising the eligibility age. As policymakers consider possible changes to Medicare, evaluating the potential effect of these changes on spending, as well as on beneficiaries' access to quality care, coverage, and out-of-pocket spending is important. Next slide. So the state issues for Medicare. States are responsible for certifying healthcare providers for Medicare patients. They are responsible to employ management methods, oversee personnel procedures, follow equal opportunity policies, and merit system procedures in accordance with federal regulations.
Next slide.
Next slide.
Okay, next slide. The beneficiaries of Medicare and Medicaid. So to qualify for Medicare, you must be 65 or older and qualify for Social Security, or be permanently disabled and receive disability benefits for at least 2 years, or have end-stage renal disease, or have Lou Gehrig's disease. And in order to qualify for Medicaid, you must be a low-income family or individual, some qualified pregnant women and children, and individuals receiving supplemental Social Security income, disabled. So that would be people that are getting Social Security for reasons of disability. Next slide.
So how is Medicare funded? Medicare is funded through the Medicare Trust Fund. Medicare is paid for through 2 trust funds held by the U.S. Treasury. These funds can only be used for Medicare. The first trust fund is the Hospital Insurance Trust Fund, and it's funded through payroll taxes paid by most employees, employers, and people who are self-employed. Other sources are taxes paid on Social Security benefits, interest earned on trust fund investments, and Medicare Part A premiums from people who aren't eligible for premium-free Part A. And what does Hospital Insurance Trust Fund pay for? It pays for Medicare Part A, which is hospital insurance benefits, like inpatient hospital care, skilled nursing facility care, home health care, and hospice care. Medicare program administration, like cost for paying benefits, collecting Medicare taxes, and combating fraud and abuse. The second part of the Medicare Trust Fund is a Supplementary Medical Insurance Trust Fund. And it's funded through funds authorized by Congress, and the premiums from people enrolled in Medicare Part B medical insurance, and Medicare prescription drug coverage, Part D. Other sources like interest earned on the trust fund investments, and it pays for Part B benefits, Part D, and Medicare program administration like costs for paying benefits and for combating fraud and abuse. Next slide. So this is a nifty little chart that shows the amounts of money that go into the different parts of Medicare revenue. And you can pause this video if you'd like and look deeper into it. I'm not going to explain too much about it. So next slide. So there were many different opinions on when this program will go bankrupt. I found a lot of very, very opinionated quotes on this topic, but I chose two that were pretty mild and seemed pretty accurate. So the first one was by the Social Security Administration, and they made the statement that both Social Security and Medicare will experience cost growth substantially in excess of GDP growth through the mid-2030s due to rapid population aging caused by the large baby boom generation entering retirement and lower birth rate generations entering employment. For Medicare, it is also the case that growth in expenditures per beneficiary exceeds growth in per capita GDP over this time period. So pretty much this is saying that because there were so many people born in the baby boomers era, that they're getting old now and they're using up all that money from the Social Security that they paid into while they were young. We, as the generation moving and aging now into the workforce, aren't as many of us paying into the Social Security fund. So there's not as much money going in as much as being used. So that leads to a problem. This other quote that was found was by the Congressional Research Service, and they said that the 2016 Medicare Trustees report indicates that although expenditures exceed income through 2015, the HI Trust Fund is projected to run a slight surplus from 2016 through 2020. Beyond 2020, expenditure growth is expected to again outpace growth in income. At that time, trust fund assets would be used to make up the difference between income and expenditures until the assets are depleted in 2028. So this service did a bunch of different data sourcing and found that the complete Social Security fund would be depleted by 2028. So take this as you will. And next slide.
All right, next slide. How is Medicare funded? Federal medical assistance percentage, enhanced matching rates, disproportionate share hospital payments, and state financing of the non-federal share. So the federal government guarantees matching funds to states for qualifying Medicaid expenditures. States are guaranteed at least $1 in federal funds for every $1 spent in state spending on the program. This open-ended financing structure allows federal funds to flow to states based on actual costs and needs as economic circumstances change. Next slide. Enhanced matching rates. So in some instances, Medicaid provides a higher matching rate for select services or populations. The most notable being the ACA Medicaid expansion enhanced match rate. For those states that expand, the federal government will pay 100% of Medicaid costs of those newly eligible from 2014 to 2016. The federal share gradually phases down to 90% in 2020 and remains at that level. There's no deadline to adopt the expansion. However, the federal match rates are tied to specific years. Slide. Disproportionate share hospital payments. So basically, if a hospital has a disproportionate number of Medicaid patients, then the federal government will subsidize by paying those hospitals more. So DSH, or disproportionate share hospital payments, are another source of financing available to hospitals. So if they have a large number of low-income and uninsured patients, then it's a crucial way for the hospitals to maintain financial stability, and it's kind of a safety net for hospitals, so they don't need to worry about patients who can't pay. Next slide. State financing of the non-federal share. So states have flexibility in determining the source of funding for the non-federal share of Medicaid spending. The primary source of funding for the non-federal share comes from state general fund. Over the past decade, states' use of other funds has increased slightly but steadily. This is likely tied, at least in part, to states' increased reliance on provider taxes and fees to finance the state share of Medicaid. And that is it for our presentation. And here's a sheet of our works cited.
All right. Good job. Hold on. Appreciate the hard work you put into this. As I alluded to early on, I think maybe we'll just go ahead and forego any question and answers. You covered the information really well. Just for everyone to know, obviously, Medicaid, Medicare is an important topic when we cover healthcare. There's a lot of controversy that's surrounded it. There's a lot of opinions, as you all talked about and Samantha alluded to, on the two different sides of it all and everything too. So I do encourage you to become even more educated about the different Medicaids, Medicares that are out there, what that means for funding for us in the future, if there is any at all, what that means for people who you might be giving care to at the hospitals you'll be working at, what opinions from physicians may feel when in regards to Medicare, Medicaid, and the like that. So I appreciate your hard work, ladies. Thank you again. I'll let you enjoy the rest of your evening and hope you have a great weekend starting tomorrow, I guess.
Thank you.
You bet. Okay, so I muted. There's some feedback, and so I muted a few of you, so I can't hear you talking, but have a good one nevertheless. We'll see you later.
Thanks. Bye.
Bye.